First presentation of sickle cell disease may be when they're 6 months old. They have swollen hands and swollen feet, and it's clear there's something bad going on. Those children are treated appropriately. They're given pain medications. Everyone wants to do everything they can to help the baby. As you grow older, you have less of those manifestations. So you can present with crisis, and there is no objective measure that they're having a painful event. And so they suffer needlessly because no one actually believes that they're in pain. It is excruciatingly painful. There was actually a recent article published that sort of tried to capture what it's like to live with this disease on a daily basis. And 30% of the patients that were studied had pain 95% of days. But they didn't see care. They saw care for like less than 20% of those days because they know they're probably not going to get the care they need. And the other is that they've learned to cope with a lot of pain on a daily basis. One of the reasons I opened this infusion clinic is because I got tired of hearing how I presented to such and such place and they didn't believe me, or they made me wait for hours and they didn't really treat me with what I knew would make me feel better. So what's going on?
Right now it's just mainly my wrist and lower part of my back. The pain is like with a 7 out of 10 scale.
When I go to the emergency room, there's a bit of a stigma where they don't want to see, it seems like they don't want to see you straight away. And I see a doctor that's not willing to give me the typical amount of medicine that will help me get out of pain. It's emotionally frustrating, and then deal with the stress of that on top of the pain already. It just makes it worse.
How's your pain level?
It's still a 7.
Once a patient has experienced 100 times over negative provider attitudes, you can imagine how they're going to feel when they present. And of course, then the provider now has more attitude because the patient has attitude, and so it becomes this circle and cycle of events which really leads to poor patient outcomes, and patients don't get what they need. Let me take a quick listen to you.
If I didn't have pain, like literally on a daily basis, it would probably bother someone that, you know, that doesn't normally experience it, but my tolerance for pain is so high, it's, you know, and I can't take like regular Tylenol or Advil or, you know, the over-the-counter medications. Those don't work. Yeah, it takes 5 to 6 milligrams of Dilaudid or morphine or both to get the pain under control, but that's what I need to get better. Whereas if I were at a facility that, you know, I visited for the first time, I'm a little reluctant to communicate that to them because I feel like they're judging me.
It used to be taught, and you can still find it in places, that if a patient tells you what dose of narcotic they need to treat their pain, that was a sign of addiction.
It's not even the verbal communication, it's the nonverbal communication that really gets under my skin, because, you know, you get this look and this tone like, okay, you've already had enough medicine, so I'm not giving you any more. Or, you know, you have to have felt something. That's the worst. When I hear, you have to have felt that. You have to, and I'm like, no, if I did, I wouldn't be buzzing you every 10 minutes telling you I'm in pain.
The last thing you want to do is to piss off one of the medical staff, because you have to rely on them for care. And with a young family, I can't afford to be there around the clock.
I feel fortunate that I have children who see what I go through every day. My oldest son, Dorian, he'll come in and plug in my heating pad, or they'll all sit around in the bed with me until my husband gets home. When I'm in the hospital, I spend my entire time looking at the clock to make sure that I'm getting my medicine on time. I can't rest. I can't, you know, I just have to make sure that after 2.5 hours, I need to start buzzing the nurse, because otherwise I won't get my medicine on time. I feel like it makes me look like that's all that I'm there for.
They, you know, don't always know if, you know, you're telling the truth or if you're just there for whatever reasons that they might suspect.
What do they suspect?
Sometimes drug seeking, or that, you're exaggerating the symptoms for just the pain meds and not because you're actually in pain.
You can't tell them anything because they're the doctors. But I don't understand, what is the point in asking me my history or what works best for me if you're going to do what you want anyway and you're still not listening to me?
I'll go through extra measures of making sure that, this is weird, but making sure that I'm dressed professionally before I go to the hospital, or not go in like sweats and, in my socks, because I don't feel like I'm being taken seriously.
It's just a remarkable thing, that I have to call ahead of time and say, so-and-so is coming in and they're a professional whatever, so therefore we're going to believe them. Whereas, this disease causes a lot of disability, and so a lot of my patients are unable to work. And so I can't call up and say, oh, they're, doctor, lawyer, whatever they are, to get them the kind of care they need. When you're sitting in an emergency room with a patient sitting across from you, what do you care if they're drug seeking? I mean, it's not your responsibility to make sure that the patient is not drug seeking. Yes, you soon send them home with 2 months worth of narcotic scripts. That's not your role in that setting. But you can treat the patient for their pain and manage their pain, and then refer them to someone who can take over the responsibility of managing their narcotics and seeing whether or not there might be an issue with their narcotic use. But in the emergency room setting, what difference does it make? If you're the person trying to make that decision, you'd hate to be wrong and say, oh, well, here's a patient who's in horrible pain and I didn't treat them because I didn't believe it. I don't want to be the provider who's wrong in making that decision, because if I'm wrong and the patient actually is in a lot of pain, I'm making that patient suffer, which is not why I decided to become a doctor in the first place. So.